Hi, you guys. This is a little bit awkward for me, but I hope that it is beneficial the way that I'm going to do it. So basically, the slides should progress forward as I click them forward, so you can just kind of sit back and enjoy the show. Luckily, you can't see me while I'm doing this. And let's see, I have a homework assignment that if you have not downloaded off of the portal, you'll want to, because it's probably going to be best to just go ahead and answer the questions as we're going through the lecture. And then in a few days, I'll be posting a review sheet that will include homework instructions that will be your final homework assignment, as well as your attendance for the week 11 lecture on the 4th of July that we are not having. Okay, so today we're going to be talking about peripheral nerves and the central nervous system. So it covers chapters 21 and 22. And this is in lieu of our in-class lecture for week 10. First, what we're going to do with the peripheral nerves and muscular disorders, we're going to cover peripheral neuropathies. So that includes something called Guillain-Barré syndrome, and the Barré part is supposed to have an accent on the E, but I couldn't figure out how to do that. The next neuropathy we're going to talk about is the diabetic peripheral neuropathy. And then myasthenia gravis, and we're going to go over muscular dystrophies kind of in general, but I'm going to go slightly more in depth into Duchenne, and I have a couple pictures of that. Duchenne is the most common and the most severe form of the muscular dystrophies, so that's why I'm going to go over that one. And then we'll also talk about neurofibromas. Okay, so just with the peripheral nerves, a little review. In general, there's the motor unit, and this is a lower motor neuron with its associated peripheral axon, as well as the neuromuscular junction and the innervated skeletal muscle fibers. And the functional elements of the peripheral nerves are the axonal processes, as well as the myelin sheath. And myelin sheaths are made by Schwann cells, and we won't really talk too much more in depth about these because I think you have probably had it in anatomy. And when we're talking about peripheral neuropathies, they can be either axonal or demyelinating diseases, or they could be kind of mixed conditions with both types of problems. And peripheral neuropathies can show up as polyneuropathies, polyneuritis multiplex, or mononeuropathies. And polyneuropathies, these are usually ones that present symmetrically, and they have what's called a length dependent fashion. So they're gonna kind of present on both sides of the body, and they're gonna affect similar lengths of the nerves on both sides. So it'll be a very symmetrical pattern, and this will have axonal loss, and it's going to be more pronounced distally. So it starts with paresthesias and numbness, loss of sensation in the toes, and then will spread upward, and this is often described as a stocking and glove pattern. Next is the polyneuritis multiplex, and this is just where there's very random damage to the nerves. And so somebody here with a condition like this might have like a right radial nerve palsy, which would cause wrist drop. They wouldn't be able to lift their hand up. And then they may also have loss of sensation in their left foot. So there's kind of no rhyme or reason to this polyneuritis multiplex, no pattern that could be predictable. And then there's the term mononeuropathy, and that just means that a single nerve has been affected, and this is usually due to like a traumatic injury or entrapment. And carpal tunnel syndrome is kind of the best example of that, where the nerves coming through the carpal tunnel have been entrapped, and they cause weakness and tingling and pain in the hands. So that would be a mononeuropathy. Okay, so the first condition we're actually going to talk about is the Guillain-Barré syndrome. That was a little attempt of mine to make an accent on the E, but it's actually going to be over the E going the other direction, so forget that I did that. And this is one of the most common life-threatening diseases of the peripheral nervous system, and it is a demyelinating disorder. And basically what happens is it affects the motor axons, and it has a presentation of ascending. So it results in ascending weakness. And the problem with this is that it starts in the hands and the feet, moves up, and then it can eventually affect the respiratory muscles. And this is one of the things that if they don't get care very immediately, they could die due to respiratory failure. Basically, the pathogenesis of this disease is that it is triggered by some sort of an infection or a vaccine, and this causes a breakdown in the self-tolerance. So then you get an autoimmune type reaction that affects the myelin sheaths of the motor axons. And common bugs are Campylobacter jejuni, Epstein-Barr virus for EBV, cytomegalovirus, CMV, and human immunodeficiency virus, HIV. The treatment, generally they'll give some plasmapheresis, which helps to remove the autoantibodies. They can also give intravenous immunoglobulin, which will suppress the immune response. And then they'll also do supportive care, so especially ventilation. If somebody is able to have the supportive care, they will generally, this condition will self-resolve with full recovery, but they have to survive that acute phase. So it's something that's extremely life-threatening, but if they are taken care of, they'll make it out just fine. Okay, the next condition that you guys will probably see very, very frequently is diabetic peripheral neuropathy. And this is the most common cause of peripheral neuropathies, and it presents in diabetics who have had the condition for a long time. And they can have a few different presentations, and they may have both or all, 1, 2, or 3 of these types of presentations. So they can have an autonomic neuropathy, and this basically affects the autonomics, so the involuntary nervous system control. They'll have bladder changes, bowel changes, cardiac effects, so arrhythmias, and then sexual dysfunction. And then they can also have something called lumbosacral radiculopathies, and this will be something that kind of starts in the lumbosacral region, and it's an asymmetric pain that progresses into the lower extremity, and there can be weakness and muscle atrophy. This can very much affect one's ability to stand up from sitting. And then they can have distal symmetric sensory motor polyneuropathy, and this is actually the most common form that you'll see, and this is where it will be bilateral and in the distal parts of the body, so hands and feet particularly, and it affects, as the name very clearly says, sensory motor activity. So the sensory axons are usually more affected than the motor axons. So it will start out with paresthesias and numbness. And this is a peripheral neuropathy that has both axonal and demyelinating damage. Basically, when you have axonal damage, there will be a decrease in the diameter of, or the density of the axons, and that slows the conduction. When you have demyelination, that will kind of affect the myelin sheath, and that will also slow the conduction, but just in different ways. So when they're looking morphologically on like a biopsy, they'll be able to notice those differences, even though the symptoms may be very similar within the two different conditions. So pathogenesis with diabetic peripheral neuropathy, there's what they call the advanced glycosylation end products, or AGEs. This is basically like that caramelization process that I was talking about a couple weeks ago, where there's a slow sugarizing effect, and this is what will cause a lot of damage in the body, and it's also kind of what we're measuring when we look at the hemoglobin A1C level. So these advanced glycosylation end products accumulate, you have hyperglycemia, you have increased reactive oxygen species, lots of microvascular changes, and changes in the axonal metabolism. And all of those things go together to create this peripheral neuropathy. And the main treatment is going to be strict glycemic control. I've also found that it can be really helpful to have good amounts of B12 in the system, and sometimes doing B12 injections can be helpful. And alpha lipoic acid has been shown to be a little bit helpful. And then there's also benfotiamine. It's spelled benfotiamine, benfotiamine, and it's a special fat-soluble form of thiamine, which can sometimes be really helpful as well. Okay, next we have the peripheral neuropathy summary. And so in general, a peripheral neuropathy may result in weakness and or sensory deficits, so those paresthesias, that numbness and tingling. They can be symmetric or with random presentation. Diabetes is the most common form of peripheral neuropathy, and then that Guillain-Barré syndrome is going to be an immune-mediated demyelinating polyneuropathy. And then I didn't talk about these, but just to be aware that there are other metabolic conditions, drugs, toxins, different connective tissue diseases like lupus, vasculitides, which is a term that kind of refers to any of the vasculitis conditions, and Wegener's granulomatosis that we talked about back in, I think that was pulmonary, has a vasculitis aspect to it, and that can result in peripheral neuropathies. And then different infections, and then you can also have inherited mutations that result in peripheral neuropathies. Okay, myasthenia gravis. This is one that's really important to know about. It is relatively common. It's an autoimmune disorder, and that it affects the receptors for acetylcholine at the neuromuscular junction. And acetylcholine kind of helps with that muscular contraction. And they don't know the cause. They think it could be related to the thymus gland, because if there is hyperplasia or a tumor in the thymus gland, this will show up, but it's not always present. Women, just because it is an autoimmune condition, you can pretty much always remember if it's autoimmune, women are going to be more affected than men. And the onset is going to be about 20 to 30 years old for females. For men, it usually will present after 50 years old. And basically what happens is there's IgG antibodies, they're autoantibodies that attack the acetylcholine receptors, and they block and destroy that receptor. And so it prevents stimulation to the muscle. And the first muscles to be affected are going to be the facial and extraocular muscles, and then the arms and the trunk. Okay, so the signs and symptoms for myasthenia gravis. This is something, it's kind of unique because it's going to be muscle weakness that gets better with rest. So the more a muscle is used, the worse, the weaker it will get, and it will improve slightly with rest. And commonly the first symptoms to appear are going to be double vision and ptosis of the eyelid, dropping lid lag, dropping of the eyelid. They'll also start to have a more monotonous speech tone because they're unable to contract the muscles in their voice box. Chewing and swallowing becomes difficult. With the upper arm and chest being affected, you can have difficulty raising arms to brush the hair and brushing the teeth. And then upper respiratory infections are common because the respirations are kind of decreased, and then eventually respiratory impairment may develop. The diagnosis of myasthenia gravis is kind of interesting and a little bit mean because the main test they use will be called the endrophonium chloride test or tensilon test. And this is where they'll actually administer a very strong but short-acting anticholinesterase inhibitor, and this will kind of prolong the action of the acetylcholine that is present, causing temporary improvement in their symptoms, but then they'll have, after that short-acting inhibitor wears off, they'll have a sudden return of their symptoms. So, I think there was an episode of House where a patient showed up with this and they gave him the tensilon test and he was like, oh my God, I'm better. And then a few minutes later, everything came back. So it's something that they, clearly counsel their patients on. They'll also find the serum antibodies, the IgG antibodies, and they can do electromyography to evaluate muscle conduction. And then treatment-wise, they're going to give some longer-acting anticholinesterase agents, as well as anti-inflammatories, glucocorticoids, and then plasmapheresis to get rid of those IgG antibodies that are present. And then if there is a hyperplasia or an adenoma in the thymus, they will remove the thymus gland. So next we're going to talk about the disorders of skeletal muscle, and these are things that can either be, the muscles can be affected secondarily by a disruption of the innervation or primarily by a myopathy. And those are what we're really going to be talking about. So myopathies can be inherited or acquired. The genetic forms, there's muscular dystrophy, congenital myopathy, and then congenital muscular dystrophy. And then there's dystrophinopathies, and those include X-linked disorders and Duchenne syndrome. And then there's acquired ones, and those can be from inflammation or toxic exposure. And really, I'm going to focus on Duchenne. Duchenne muscular dystrophy happens at about 1 in every 3,500 live male births. It is an X-linked disorder, so therefore it's going to affect males more frequently. It is eventually fatal. It becomes clinically evident by about age 5, and by the teenage years they're going to be wheelchair bound. Usually by their early adulthood, 18 to 25 or so, they will die. And it's caused by a mutation in the dystrophin gene, and dystrophin is a protein that is present in skeletal muscle, cardiac muscle, and then also in the brain and peripheral nerves. And it stabilizes the muscle cell during contraction. And what will actually show up with these patients is that they are kind of clumsy. They oftentimes will walk on their toes, and their pelvic girdle is what's affected first, and then also the shoulder girdle. And so the pelvic girdle is really important in being able to stand up from sitting and to be able to kind of maintain upward posture. And the shoulder girdle is also important in really, maintaining our balance and our strength. They'll also have enlargement of the calf muscles, which is called pseudohypertrophy. So they'll look like they're crazy strong sprinter legs, but they're extremely weak. And then eventually the cardiac involvement of this dystrophin defect will lead to death. And I've got a couple of pictures here. So there's something called Gower's sign. And this is something that in order to be able to stand up, the child will have to do something kind of funky. And they'll be on, their hands and their feet. They will walk their hands or their legs forward, hands back, legs forward, and then they will lift a hand to their knee. And then they will press their hands against their knees in order to right their torso. And then they kind of have to let their arms fall back a little bit to balance themselves. Here's just another picture. So here's a little kid. He's kind of got a funny posture where he's holding his arms back a little bit. And then he's got a sway back. So his body kind of leans back, and that's mainly just to kind of right the posture. And eventually once they're in the teenage years, they're going to have a lot of distortion of the body due to the muscle damage, and they'll have some hypertonicity. And then the picture at the bottom, you can see just a little bit of hyperplasia in the calf muscles. It just looks like their muscles are very developed, though they are very weak. Okay, the next one is called the neurofibromas, and there's a lot of different ways that this can present and with different conditions. In general, they're benign peripheral nerve sheath tumors. So they're tumors that present on the nerve sheaths, and they can be localized either to the cutaneous tissues. They can be plexiform, so kind of gathering around the nerve plexi, or they can be very diffuse and infiltrating. And the diffuse ones are very disfiguring, and I'll show you a couple of pictures. There's a hereditary condition, an autosomal dominant disorder called neurofibromatosis type 1. And this is caused by mutations in the tumor suppressor gene neurofibromin. And basically, most of the people, like people who have neurofibromatosis, will have about 50% of those cases will have malignant transformation from a neurofibroma that they have. Otherwise, normal people who do not have neurofibromatosis, there's kind of about 50% of the malignant peripheral nerve sheath tumors will happen in people who don't have neurofibromatosis. 50% of them happen in people who have neurofibromatosis, and they were benign that moved into malignant neurofibromas. And basically these fibromas just create themselves all over the body with neurofibromatosis. And they can have, like I said, they can have the malignant peripheral neurofibromas. They'll have optic gliomas. And if you look up pictures of these, they're extremely disfiguring and actually very hard to look at. They'll have glial tumors. Those can be present in the brain. They will have learning disabilities, seizures, skeletal abnormalities, vascular abnormalities. And then they can have some changes in the pigment of the skin. And sometimes they'll have what's called cafe au lait spots or coffee and cream spots on the skin. This one would be one, just search, Google neurofibromas in the images world, and you will see a lot of very interesting pictures. The first one that I have to show is just the cutaneous neurofibromas, and this is somebody who has neurofibromatosis where their body is just covered in these neurofibromas. And this next picture is a poor little kiddo who has it, and you can kind of tell under the lid there's kind of some lumpy things, and then you can see his mouth is even extremely deformed, in his cheek, and those, he probably has a glial fibroma, sorry, an optic glioma. And then they can present very deep in the tissues, so his face is extremely disfigured by this condition. Okay, so we're going to move into the central nervous system, and I've got a number of conditions to go over. I'm just going to talk a little bit about increased intracranial pressure and the signs and symptoms that you'll want to look for with that, because that increased intracranial pressure can present with many of the neurological conditions that we're going to talk about. And then we'll talk about cerebral edema and cerebrovascular accidents, or CVAs, aka strokes, aneurysms, that kind of thing. Then neural tube defects, meningitis, multiple sclerosis, metabolic brain diseases, dementia, including which I'm really going to go over as Alzheimer's. There's a couple of other causes, and then Parkinson's disease, ALS, or Lou Gehrig's disease, brain tumors, meningiomas, and metastatic tumors. Okay, so just in general, if there is neurological dysfunction, you can see increased intracranial pressure. And this can be caused by a hemorrhage, a trauma to the brain, and swelling, infections, tumors, and then if there's an accumulation of excessive cerebral spinal fluid, you can have increased intracranial pressure. So what happens is early on, you're going to see the body's going to compensate by shifting more cerebral spinal fluid into the spinal cavity, and just to kind of get the pressure down in the brain. And this will show up as decreased level of consciousness, so some lethargy, severe headache, sometimes vomiting, and then they may have papilledema. So this is where if you're looking into the retina of the eye, you'll see some swelling of the optic disc. Their vitals will change, and here we run into Dr. Cushing again, who liked to just name everything after himself. And there's the Cushing's reflex, and this is where they'll have an increased blood pressure, and this is it's basically vasoconstriction. It's trying to send more blood to the brain, hoping to decrease the damage to the brain. They'll slow the heart rate, and this is just the baroreceptors that are responding to the hypertension. There will be a reduced respiratory rate, and this is those chemoreceptors again in the medulla of the brain that are responding to low carbon dioxide levels. And then they'll have an increased pulse pressure. And basically that pulse pressure is when you take somebody's blood pressure, the systolic number minus the diastolic gives you the pulse pressure. So if it's, the normal is 120/80, so that's, a pulse pressure of 40, and if the pulse pressure is increased, it's a good sign that there could be some intracranial pressure increase. And then visual signs, cranial nerve 3 is affected, and it's going to affect the size and the response of the pupil, as well as it helps to lift the eyelid. So they can get fixed and dilated pupils, either on one side or both. And on both sides, it usually means it's much more severe intracranial pressure increase. They can get ptosis again, so that lid lag. And then they can also get nystagmus. And I've got a couple of pictures of these visual signs that you'll see. So here is ptosis. Basically, you can tell this man's right eye the eyelid is drooping. And you can really tell that by looking at the pupil and seeing that you cannot see the light reflex on his pupil in the right eye. Then if you can kind of stop the lecture and click on this link. It'll take you to a video that shows you what nystagmus looks like. And whenever you do see this in somebody, it should be evaluated urgently unless it's been a chronic problem. I had a patient who had a cerebellar tumor, and she had it removed, and by the time I saw her, she had gone through all of the treatments. It was a benign tumor, but she had gone through all of the treatments. She had to have a shunt placed to help drain the cerebral spinal fluid because she wasn't able to drain or have her cerebral spinal fluid circulating very well, and she just had a chronic right eye vertical nystagmus that left her feeling really dizzy, and it would cause lots of headaches because her eyes were trying to focus but having difficulty because of that nystagmus. Okay, so next we have cerebral edema, and this can happen for a variety of reasons, but basically it's the accumulation of excess fluid within the brain parenchyma, or the brain tissue. And an edematous brain is going to be somewhat softer than normal, and so the gyri, which are kind of the hills of the brain, and the sulci, which are the spaces in between the hills, the gyri are going to be somewhat flattened, and then the sulci are going to be narrowed. And then you'll be able to see that on imaging, the ventricular cavities, the ventricles are what kind of create and help circulate the CSF. Those cavities are going to be compressed. And it's basically the brain tissue is going to be expanding into those areas. You can have vasogenic edema or cytotoxic edema. And vasogenic edema is going to happen when the integrity of the normal blood-brain barrier is disrupted. And this is where there will be fluid shifting from the vascular compartment into the extracellular spaces of the brain. And this can either be localized to one area or generalized. And when it's localized, it's usually due to a local inflammation or tissue damage. It can also happen with a tumor that is creating a lot of inflammatory markers. And then with the cytotoxic edema, this is where it's going to actually be increased intracellular fluid, whereas the other is extracellular fluid, and this is going to be secondary to actual brain cell membrane injury. And this is usually due more to a hypoxic or ischemic insult. And I have two personal stories about this, and I'm going to ask you about these on the homework, just because they've been pretty interesting experiences for me personally, but then also when I can kind of step away from them and look at them in more of a clinical manner. So my brother had an 8-month-old daughter who he found her one morning. She was not breathing, and he didn't know how long she had not been breathing, but she had no pulse. So he immediately started to do resuscitation on her, and actually did get a pulse back. And by the time the ambulance was there, she had a pulse, but she wasn't very conscious. She really wasn't conscious. They ended up flying her to the hospital in Portland, and she was on life support for about 5 days. And they actually kind of cooled her brain for a little while, and this was because of the hypoxic damage. She was getting this increase in intracellular fluid, so she was getting cytotoxic edema in her brain because of a hypoxic event, and that led to brain swelling, and she had a lot of signs of increased intracranial pressure. And she was showing certain signs, something called posturing, and it's when there's been enough brain damage that you don't have your kind of more developed neurological responses. You have much more, what's the word? You have much more kind of older innate responses. And basically, if her body was touched, her arms would kind of straighten and come into her body, and it's kind of a protective thing, but it's very, very immature in terms of brain functioning. So we kind of knew that her cortex was not functioning quite as well, and that was much more of a brainstem reflex. So that was an example of hypoxic damage to the brain, and she had so much damage that she was not able to live on her own. In terms, she had to be on a respirator and that kind of thing. So they made the choice to disconnect her from the machines. My second experience is the same brother. That family has been through a lot. His second child was born with a cord around his neck, and was again had a hypoxic period of time, and they don't know exactly how long he was without oxygen. But in this case, what they did was they actually cooled his body for 3 days. So what is that? 24, 48, 72 hours. They cooled his body temperature down to 93 degrees, and they basically did that by laying him on what they called a cooling blanket. And this was to actually prevent the cytotoxic edema that can happen with hypoxic events. And they kept him cool for about 3 days, and then they warmed him back up, and he really did really well through that whole process. And so he has absolutely no neurological deficits from having had a hypoxic event, because he was able to not have to go through the cytotoxic edema that can happen post-hypoxia. Okay, next, we're moving into vascular events, and these events, they can be either hemorrhagic or ischemic, and so that means they can either be caused by bleeding into the brain or by a blockage of blood going into the brain. And the very shortest example of this would be what's called a transient ischemic attack, or a TIA. And these are temporary and very localized reductions of blood flow. And usually the people will have complete recovery within 24 hours. And so the pathophysiology of this is just that there's a very partial occlusion of an artery that does not last long enough to create death of brain cells. And so the etiology, you're going to find this with people who have atherosclerosis. It could also be from a thrombus or an embolus. And then sometimes someone will have just a small vascular spasm that will cause a little bit of ischemia. And this is an early warning sign of a stroke, but not all strokes are going to be preceded by a TIA. So if someone does have a TIA, it's something that they need to be worked up for more serious problems, though they could, their initial presentation could be a full-on stroke. So again, the signs and symptoms, it's a local, it's going to depend on the location of the ischemia, but they are going to have, their level of consciousness is going to be maintained. So they're going to be generally aware of what's going on. And they're short episodes of muscle weakness, numbness, and maybe paresthesias. They may have some transient aphasia, so difficulty speaking or kind of garbled words and confusion. And they will last a couple of minutes up to a couple of hours. And then they'll have full recovery, so no damage is done to the brain cells during this time. In comparison, a stroke is damage to the brain cells, and usually this is going to be in people over the age of 65, and etiology is really the same as a TIA. A stroke can also happen with an aneurysm rupture, which we're going to talk about aneurysms separately. Hypertension is going to increase the risk, diabetes mellitus, systemic lupus erythematosus, or lupus in general, the autoimmune condition, hyperlipidemia, ischemic heart disease, sleep apnea. If somebody has endocarditis, which is an infection of the interior lining of the heart where they can get those accumulations on the valves, one of those can embolize into the brain. So there's a lot of different things that can cause strokes. The pathophysiology, again, they can be ischemic or hemorrhagic, and TIAs generally are ischemic, whereas strokes can be ischemic or hemorrhagic. So there can be occlusion by an atheroma, which would be a plaque, a thrombus, or an embolus, and this will lead to tissue necrosis, and lack of blood supply for about 5 minutes will lead to irreversible brain damage. Initial necrosis, you're going to get some edema and inflammation, and then later this will actually start to liquefy the brain and leave a little cavity in the brain, open space. With intracranial hemorrhage, you will actually get more signs and symptoms of the increased intracranial pressure, and oftentimes that will show symptoms in both hemispheres, because with hemorrhage you're going to have accumulation of fluid which will compress the area around it, and by compressing the area around it, it's also going to be compressing the rest of the brain tissue. So usually you're going to have more global symptoms with a hemorrhagic type stroke. So we always want to kind of assess for the risk factors for stroke, because we know that prevention is better than actually having a stroke. And then treatment-wise, they're going to rule out a hemorrhage before they do this, because oftentimes if you give like a clot-busting drug to somebody who's having a hemorrhagic stroke, it's going to result in worse bleeding. So as long as it is not a hemorrhagic stroke, they're going to give some clot-busting agents, and then for all of them, they're going to give glucocorticoids to reduce the swelling. Here's an example of an MRI, and this is actually a newborn, but I wanted to just kind of show the stroke and the effect. So A says this is a head CT on day 3 of life showing focal hypodensity. So the arrows are pointing to an area that has been damaged. And this is consistent with a right middle cerebral artery infarct. And let's see. B is an MRI that is T2 weighted, and when you hear about MRIs, there's T1 weighting and T2 weighting, and T1 weighting is going to emphasize fatty tissues more, and T2 weighting is going to emphasize or light up the watery areas more. And so B is showing where the brain tissue, which would be fatty tissue, has actually been filled with water or blood and is no longer really showing up as fatty tissue. So there's been some damage there. And okay, I think that's pretty much what I wanted to say with that one. And so really just the warning signs that you want to watch out for with stroke, they're going to obviously depend on the location of either the obstruction or the bleed and the size of the arteries. So they could be very, very localized symptoms or quite diffuse symptoms. You may see some flaccid paralysis, so that's initially where there will be just weak, limp paralysis. Once the person has kind of healed from the paralysis, you're going to see spastic paralysis. And if you remember back to anatomy, physiology anatomy, where they're going through the upper motor neuron lesions versus lower motor neuron lesions, usually lower motor neuron lesions are actually going to be the flaccid paralysis, but initially when there's an upper motor neuron lesion, there's going to be flaccid paralysis, but once they get over the acute part, they'll have spastic paralysis. And so that's going to be where there's more hypertonicity. And they may go straight into a coma if it's very widespread. With the anterior cerebral artery, this affects the frontal lobe, and they may have some contralateral muscle weakness, sensory loss, confusion, personality change. And that frontal lobe, really the personality change is because of the frontal lobe. That's where your personality comes from. If it's a middle cerebral artery, they are more likely to get problems with speech, and then they may have contralateral paralysis and sensory loss in the upper body and arm. If it's the posterior cerebral artery, that's the occipital lobe where the visual cortex is, and they will end up with vision loss. So here is just a quick way of determining what to do. If somebody's face is uneven, if their arm is weak, if their speech is strange, it's a good idea to just go ahead and call 911. Okay, next we have aneurysm, and this is basically where there's a localized dilation in an artery, and it's usually going to be near a bifurcation, just because the pressure at the point of bifurcation is going to be higher, because blood flow is going from a larger vessel into 2 smaller vessels. And the circle of Willis in the brain, which I have a picture of coming up, is the most common location, and they're usually berry or saccular aneurysms, and I'll show you examples of different types of aneurysms. And etiology for an aneurysm, hypertension is one of the most common causes because that's going to increase the pressure and increase the likelihood of aneurysm formation. And then some people will also have a weakness in their arterial walls. And so the pathophysiology of a ruptured aneurysm is that there is blood that is under arterial pressure that is being forced into the subarachnoid space. And this bleeding is going to cause a reflex vasospasm, which will then kind of reduce the overall perfusion of the brain. But because there's blood that has gotten out of the vascular system into the extracellular space, they're going to get an increased increased cerebral pressure. And the signs and symptoms, they can have visual changes, loss of their visual fields, different cranial nerves can be affected, headache, photophobia, confusion, slurred speech, nuchal rigidity. And nuchal rigidity is a stiff neck, and that's because there may be some blood that's irritating the spinal nerve roots that's kind of moving through the CSF. And then if it's very massive, they may end up with splitting headache, vomiting, seizures, loss of consciousness, and death. And if it's diagnosed before the rupture, the aneurysm can actually be clipped or tied off. And there are certain therapies that you can do to reduce the intracranial pressure and the vasospasms if it does rupture. But about 35% of patients are going to die with that initial rupture. So here's just a picture of the location of the circle of Willis. It's here kind of just anterior to the brainstem, and pretty much provides all of the blood flow to the brain. And here is just an example of a saccular or berry aneurysm. It's the most common type of aneurysm. Here's another type of aneurysm, a giant aneurysm. You can also just have this fusiform aneurysm, and this kind of resembles what we were looking at when we looked at the abdominal aortic aneurysms, where it's just completely dilated. And that, if it ruptured, would be extremely severe. And here is a blurry picture of that circle of Willis again. And here's the basilar artery that kind of runs along the brainstem and goes out and creates the middle cerebral artery that serves the temporal lobes, the posterior cerebral arteries here that are going to serve the occipital lobe. And here's the internal carotid coming up from the neck, and then the anterior cerebral artery kind of goes to the frontal lobe. And here's just the percentage of how frequently an aneurysm will occur in these different locations. So most commonly they're going to be around the anterior cerebral artery with that communicating artery in between. Okay, and then here is, you can see on this cerebral angiogram, a little saccular aneurysm sitting out here. And what they can do is go in and clip it, and I'll show you what a clip looks like. Basically just clips the base of the aneurysm so that blood cannot flow into it. And so here, post-surgically, you can see that that aneurysm is no longer filling with blood. And it looks like they may be getting some better blood flow up here, further distally from that aneurysm. And these little clips just clip around the base and prevent any blood from flowing into the aneurysm. Okay, so next we're going to talk about the neural tube defects, and most commonly this is referred to as spina bifida. There's also, it's basically a group of defects. So spina bifida, myelomeningocele, and spina bifida occulta that we're going to talk about. Myelomeningocele are the most common type, and they happen in about 1,500 to 2,000 of the 4 million live births per year in the U.S. And this is basically where there's going to be a cleft in the vertebral column, and then there's going to be a defect in the skin, and the meninges and the spinal cord are going to be exposed. And I'll show you pictures of this. So pathophysiologically, during gestation, the neural tube is going to develop in the 4th week of gestation, and fusion begins in the cervical region and then proceeds both headward or cephalid and caudally towards the tail from the cervical region. So usually that very initial closure of the cervical region happens, and then the defects may be either above or below that. The most severe deformity would be anencephaly, where the actual brain does not form. But what we're going to talk about are really the problems that can happen caudally. So the cranial neopore is going to close around the 25th day after conception. And the fusion at the caudal end is slightly delayed so that the caudal neopore can remain as an open communication. And then this is going to close eventually. And basically if there's a problem, this process can be interrupted, resulting in non-closure and what they call a neural tube defect. And this is where they've started recommending folic acid as a supplementation during prenatal times and during early gestation to prevent these changes. And so again, the different types in more depth. There's spina bifida occulta, and this is where the spinous processes actually do not fuse, but there's no herniation of the spinal cord or meninges. And it may actually not even be visible, but usually there's just a little tuft of hair present over that site. And commonly it's in the lower lumbar area, where somebody might just have a darker patch of hair. And then on x-ray they could tell that the spinous processes did not fuse, but the spinal cord is still going to be maintained within the spinal column. A meningocele, it has the same bony defect as spina bifida occulta. However, there is some herniation of the meninges and the CSF, and it's going to form a sac on the surface. And you can shine a light through this little sac and see the nerve tissue within the sac. And there's a risk of rupturing that sac, which could result in infection directly into the nervous system, central nervous system. And then the last is called myelomeningocele, and this is the most serious, and this is where there's a herniation of the spinal cord and nerves along with the meninges and the CSF. So with the meningocele, it's just the meninges and the CSF that are herniating out. With the myelomeningocele, it's the spinal cord, all of the nerves, the meninges, and the CSF. So it's very, very severe. And they're going to have some neurological impairment. And this is a condition that's commonly also seen with hydrocephalus, or increased accumulation of cerebral spinal fluid due to inability to circulate the CSF properly. And etiology, they're generally multifactorial. There is a genetic or familial link. Then they also feel that environmental exposures like radiation can be very damaging. And then gestational diabetes is going to be one of the causes, a lack of vitamin A during pregnancy, which you have to be kind of careful because more vitamin A can cause defects in the baby. And then folic acid as well. So they really recommend taking folic acid and a little bit of vitamin A during those first 6 weeks of pregnancy. And then signs and symptoms, we kind of went over this before. Generally the meningocele and myelomeningocele, these are going to be visible with a protruding sac over the spine. And then the myelomeningocele, the deficits are going to depend on the level of the defect, and they will have sensory and motor deficits, so muscle weakness and paralysis, and usually they will also have bowel and bladder control impairment. Diagnosis, they can do a blood level in the mom's blood of alpha fetoprotein, because it's going to be leaking from the defect, and they will check that around weeks 16 to 18 of gestation. On ultrasound, they can see the spine very clearly and can see if there's a defect, and usually they'll do that ultrasound from weeks 18 to 22 to make sure that everything has closed up. they can also do an amniocentesis to detect that alpha-fetoprotein. And now they can actually do surgical repair in utero, which is amazing, but they may also do surgical repair postnatally. And this is just an example. So over here on the left, we've got a normal spine and spinal column. So all of these spinous processes have formed, and the spinal cord is within the spinal column. And then over here, this is spina bifida occulta. We have lack of this spinous process here, which looks like our L5 right above the sacrum, but everything is intact. The spinal column and the spinal cord are all where they should be, but they've just got this little patch of hair. Totally fine, no, problems that they'll notice. And then here with the meningocele, they're going to have a sac that's protruding. First off, they don't have that spinous process here, and then the meninges and some CSF are protruding out in a sac, and it's covered by a thin layer of skin, but you can still transilluminate that with a light and see that that's fluid. And then the most severe here, we've got the tail of the spinal cord, or the cauda equina, that's actually protruding out here through the myelomeningocele. And basically from here, from the level of L4 down, they're going to have some neurological deficits. And this is just a picture of a myelomeningocele in a newborn. So you can see here, it's taking up much of the middle back, and you can see some nervous tissue in here. That is, oh gosh, about 3.5 inches long. Okay, and so next we're going to talk about meningitis, and this is basically inflammation or infection of the meninges, and early diagnosis is very essential, otherwise there can be brain damage and death. And commonly meningococci or meningococcal meningitis is one of the most commonly heard of, and this can occur through nasal spread to the brain tissue, the meninges. Then E. coli is a common causative agent in neonates. Haemophilus influenza is a common cause in children, and then strep pneumoniae will usually get more elderly people as well as children, and it can be secondary to sinusitis or otitis, ear infections, an abscess in the bone or the teeth from the teeth can spread to the meninges. And then pathophysiologically, basically the microorganisms are going to reach the brain via the blood and cause direct damage. And generally, you're going to have a lack of very focal neurological signs because the infection is going to be very generalized, and they will show signs of increased intracranial pressure. And then bacterial infections may result in a purulent exudate that's going to fill the spaces in the brain. And they could see that on imaging. Signs and symptoms, usually there's a very sudden and severe headache, photophobia, stiff neck. They may have convulsions or seizures, fever and chills, rash on the skin. I'll show you some pictures of these. Vomiting, delirium. They'll have Brudzinski sign, which when the neck is passively flexed will cause flexion of the hip and knee. So here's just a picture of where the meninges are in the brain, and then when they're infected and become swollen, you can see how there's pressure pushing in on the brain. And this very healthy looking guy who they're depicting has meningitis is going to have a very severe headache. He may have an altered mental status. He will be sensitive to light and sound. He'll have a stiff neck, high fever, and then this meningococcal infection will cause a rash on the trunk and mucous membrane, so inside the mouth. And it looks petechial, so kind of little hemorrhaging under the skin. And here's a patient who actually has this meningococcal petechial rash. And then this little guy, when he's laying there just fine, and then when the doctor just passively flexes his neck, his legs are going to reflex back and bend up, and that's just due to irritation of the meninges. So the diagnosis is usually through lumbar puncture, and they'll analyze the cerebrospinal fluid, and on the lumbar puncture they can evaluate the pressure within the cerebrospinal fluid. And then treatment is going to be directed towards the causative agent. They usually will also give anti-seizure meds and steroids. And mortality rate in infants is very high, and the risk of brain damage is occurs in about 10 to 20% of people. And this is mainly why they give vaccinations for meningococci, strep pneumoniae, and H. influenza to prevent meningitis. Here's just a picture of the lumbar puncture. So here you can see that they have this needle that goes in, and it can measure the pressure here on this gauge, and then the fluid they will collect and analyze. And they'll usually do this between the 4th and 5th lumbar vertebrae. And they want to be careful not to actually hit the cord. They just want to go in and get fluid. Okay, moving right along. Next we have multiple sclerosis. So this is a progressive demyelination of the neurons in the brain, the spinal cord, and the cranial nerves. And it's relatively common, 1 in every 1,000 persons, and it's the second most common cause of disability in the United States, the first being motor vehicle accidents. And this is most commonly comes on between 20 and 40 years old. Women are twice as affected as men, and they don't really know the cause of multiple sclerosis. There is one theory that it could be a viral infection that results in an abnormal immune response. Genetics definitely play a factor into it. Immunology plays a factor into it, and some environmental components. And people with European descent are going to be more at risk. And so basically what happens is there's an immune-mediated inflammatory response that attacks the myelinated axons. So this is a demyelinating disorder, but it's not a peripheral nervous system disorder. It's a central nervous system disorder. And basically there are kind of relapsing and remitting symptoms, and that's what kind of sets MS apart from other neurological conditions, is that there will be a flare, and that's the relapse, and then it will remit and maybe be fine for quite a long period of time. So again, that relapsing and remitting really sets multiple sclerosis apart. And the signs and symptoms are going to be variable depending on the location of the brain that's affected. And so they could have some blurred vision, double vision, weakness in the arms and legs, paresthesias, chronic fatigue, loss of position sense. And these are going to be, again, relapsing and remitting. Unfortunately, there's no definitive test. The history, when the patient says they've had exacerbations as well as remissions, that's going to tip the practitioner off to maybe think about multiple sclerosis. On MRI, they can see the demyelination and the CNS lesions, and they may have elevated protein levels, gamma globulins, and lymphocytes in the CSF. So they will also oftentimes do a lumbar puncture to kind of put that information along with their history and potential imaging findings to make a diagnosis. And treatment, they'll do interferon and various immunosuppressants like the intravenous immunoglobulin and glucocorticoids. They also do use muscle relaxants because you can get some hypertonicity of the nerves because of that upper motor neuron lesion activity. And then this is just a slide to kind of touch on how different metabolic disorders can affect the brain. Hypoglycemia is mainly going to affect the hippocampus of the brain, and the hippocampus is where you create your short and long-term memories. So hypoglycemia can really affect memory. And then hyperglycemia, we talked about the ketoacidosis in the endocrine lecture. This will really lead to more confusion, stupor, and potentially coma. And then with the hepatic encephalopathy, they're going to have some kind of depressed level of consciousness, possibly coma. But in early stages, they're going to have something that's pretty kind of remarkable, where if the patient has their arms extended with their, palms, instead of pals, with their palms facing the observer, their hands will flap. And it's kind of a tremor, flapping tremor, and this is called asterixis. And basically, because the liver is responsible for clearing ammonia in the urea cycle, the elevated ammonia is the major culprit in causing these neurological problems. So next we have dementia, and I'm really going to talk mainly about Alzheimer's disease. This is really quite common. So 10% of the population over 65 and about a quarter of the population over 85. Somehow, again, females are more affected than males, and they really don't know the cause. There are some genes that are associated really more with early onset Alzheimer's disease. And there's also the new theory that this is kind of the type 3 diabetes. So this might be how glucose dysregulation manifests in the brain over the long term. But basically there's progressive cortical atrophy, and they'll see dilated ventricles in the brain. And then they develop these neurofibrillatory or fibrillary tangles in the neurons, and plaques will form. And the plaques disrupt the neural conduction. And they have precursor proteins called beta amyloid. And there's also, just in general, a deficient amount of acetylcholine present. So they try to use, treatment-wise, things that are going to prolong acetylcholine. Symptom-wise, very early on, they're just going to have a gradual loss of memory and lack of concentration. They may have an impaired ability to learn new information, and frequently they'll have behavioral changes that may include irritability and hostility. Their cognitive function, just general memory and language decline, and eventually they'll have difficulty even recognizing family, and they will stop really being aware of their environment. And then they may also develop some incontinence. They just don't have the awareness of their body that they used to. So clinically, oftentimes it's good to start out with a mini mental status examination. This kind of goes through short-term memory to see if they're able to hold on to information. You can find many mental status examination questions if you Google them. But there's really no definitive diagnostic tests. They will kind of back it up with imaging. And then again, the treatment, they're going to try to do anything that will increase their acetylcholine levels. And then prevention-wise, they have found that estrogen, bioidentical estrogen supplementation, as well as bioidentical testosterone supplementation in men, estrogen in women, testosterone in men, 10 years before the onset can help prevent it. But then again, you don't know if you're going to get it, so it's one of those things that some people recommend men and women both to get their supplementation early. Other forms of dementia, you can have vascular dementia, and this is just due to some small infarcts in the brain. You can also have Creutzfeldt-Jakob disease. This is a prion disease. And then last, you can have AIDS dementia, and this occurs in the later stages of AIDS, and it's basically when the virus invades the brain tissue, and you'll have a gradual loss of memory and impaired motor function. So next is Parkinson's disease, and Parkinson's disease is the most common cause of Parkinsonism, and Parkinsonism is a syndrome that includes a resting tremor, rigidity, bradykinesia, and postural instability. So resting tremor is a tremor that gets better with intention or activity. So my hand will be tremoring until I go to write something, and then with my intention or with my activity, the tremor usually will go away. There's also some muscle rigidity, so kind of locked muscles, and then bradykinesia, just slow movement, inability to really coordinate movements, and then they'll also have some difficulty with their postural stability. Dr. James Parkinson was the first to describe this in 1817 when he wrote an essay on the shaking palsy. And there's an herb called mucuna, which has L-dopa in it, and that was used in ancient times to treat these types of symptoms. So it has levodopa in it, and levodopa is basically the pharmaceutical that they use to treat Parkinson's. About 5,000 individuals develop this yearly in the U.S., and it affects men equally to women, usually develops over age 60. There are some genes that have been identified in hereditary cases, and there's some research that shows that viruses and toxins may also cause Parkinson's disease. And there's also some mitochondrial changes that show oxidative stress leading to free radicals that they found in Parkinson's disease. Secondarily, people who have had encephalitis, trauma, or vascular disease may get kind of a secondary Parkinson's disease where the substantia nigra is affected by the encephalitis, the trauma, or the vascular disease. And so pathophysiologically, what happens is there's a progressive degenerative change in the basal nuclei of the brain. And really this is going to mainly take up the substantia nigra. And there's going to be decreased number of neurons that secrete dopamine. And dopamine being low, will kind of create an imbalance between excitation and inhibition of the basal nuclei. So you get some abnormal signaling there. And you can also eventually get a decreased number of cortical neurons, and so you can have a Parkinson's associated dementia as well. If you look this one up, they have a decent amount of there's what's called a shuffling gait. So they kind of shuffle along and their posture is kind of bent forward. And then they'll have what's also termed a masked face, because their facial muscles don't move quite so easily, and so they aren't really able to show facial expression. Okay, moving on, we have amyotrophic lateral sclerosis, also called ALS, or Lou Gehrig's disease. And Lou Gehrig was a famous baseball player who had this condition. And it's extremely, extremely devastating. It's a progressive neurodegenerative disorder that will result in muscle weakness, disability, and eventually death. Median survival is about 3 to 5 years once the onset happens, and most of the cases are just sporadic forms. So 90 to 95% of cases are just going to be kind of spontaneous presentation with no family history. Risk factors, the only established risk factors they have are age and family history, and usually the onset is after 40 years old. There is some evidence that shows that cigarette smoking can increase risk of ALS. So basically there's a progressive upper motor neuron defect in the cortex, but then there's also lower motor neuron effects in the brainstem and the spinal cord. And they have found that there's absolutely no inflammation that's causing the changes. But there are the glial cells, which are kind of supportive cells, do secrete a neurotoxin that leads to death of the motor neurons. The part of this that's extremely devastating is that the sensory neurons, the cognitive function, all of the cranial nerves and eye muscles are unaffected. So these people end up being kind of locked in because they have no muscle control, but they have all of their wits about them, basically. And the loss of the neurons is very diffuse and asymmetric. And eventually it is going to affect respiratory function. So signs and symptoms: upper extremities, they'll have weakness and muscle atrophy, loss of fine motor coordination, stumbling and falling is very common, muscle cramps, and then the paralysis is just going to progress through the body. And dysarthria, very difficulty speaking, swallowing, breathing. Eventually they will require a ventilator. And diagnostically, there are some biomarkers that they can find in the CSF, but these are still in the research stage. They will do nerve conduction velocity tests and muscle response tests. And so far, there is no real treatment to date. And I actually had a classmate of mine who, she was a little bit older. She probably was in her very early 40s, and she was actually a resident of mine. And she always had this lisp. She kind of talked with a lisp. And about a year or two after she had finished her residency, she was diagnosed with ALS. And about 2 years after that, she was almost completely wheelchair bound. And I think she's still alive, but it's been a very, very sad decline for her. And the very first signs were that lisp, and she did have a little bit of a lid lag. Seemed like her eyelids were not quite as active as they should have been. Okay, so brain tumors, I'm just going to cover these very, very generally because there are a lot of different types, and they can come up in the meningeal cells, within the brain cells, other central nervous system cells like the lymphatics, or they could be secondary metastases from another location. And really, even if they are low grade or benign, they may have very poor clinical outcomes just because of where they are and what they affect. Kids are more likely, oh gosh, I spelled that wrong. Pediatrics are more likely to have medulloblastomas or pilocytic astrocytomas. Older patients more likely to have glioblastomas and lymphomas. I'm not going to ask you to remember any of those, but do remember that even if it is a benign cell tumor, it can have very, very, bring with it very poor clinical outcomes just from compressing tissue around it and affecting different neurological functions. And brain stem and cerebellar tumors are more common in kids. The tumors from the brain may metastasize to other parts of the body, as well as metastases from breast or lung tumors may end up in the brain. And you will get, and this is something to remember, that with brain tumors you will get signs of an increased intracranial pressure. And so those could be morning headaches, vomiting, lethargy, personality changes, generalized seizures, pituitary adenomas, and so the pituitary adenomas can actually cause hormonal abnormalities or visual changes. And treatment is going to be surgery if accessible, chemotherapy, and radiation. It's very difficult to deliver drugs to the central nervous system, mainly because of that blood-brain barrier, so they can be hard to treat. Okay, here's a picture of a brain tumor, and you can see how the tumor up here in the frontal aspect of the brain has changed the layout of these ventricles, has caused some compression, and is likely affecting a decent amount of the brain at that point. Okay, I think that's the end. And again, don't forget to check for the homework assignment online. If you didn't do that already, at the end of this lecture, you should be able to answer those questions. And please feel free to email me with your questions or call. So my email is dr.cleveland.job@gmail.com, and my phone number is 503-384-8315. Have a nice couple of weeks off. Thanks, you guys.